Hi. Welcome to Maribeth and I's presentation on muscular dystrophy.
There are multiple types of muscular dystrophies out there. However, all of them have some commonalities, such as decreased strength and how it can progressively weaken the child. This can lead to a loss of functional mobility, which is a big area where PT come in to intervene. Muscular dystrophies in general are genetic, degenerative diseases primarily affecting voluntary muscles. Muscle weakness will begin at a very young age. However, this age can vary in the different types of muscular dystrophies, and they can progressively worsen. In some cases, children will need to use a wheelchair by their young teen years. Some forms of muscular dystrophy can lead to death at a very young age, while other forms have a lifespan well into adulthood. For this project presentation, we'll be focusing on Duchenne's muscular dystrophy. So Duchenne's muscular dystrophy is also known as DMD for the abbreviation. It's the most common X-linked disorder. So muscle cells are kept intact by a protein called dystrophin, but in DMD, the protein dystrophin is actually missing. This means that the pathology of this disease results from the fragility of the muscle membrane stability during contraction, which results in hypoxia of the muscles. Together, this results in loss of muscle mass and replacement of muscle with fat and connective tissue. Basically, when dystrophin is not present, then there is an intolerance to the mechanical forces that are experienced during muscle contraction. DMD is mostly seen in young boys as an X-linked inheritance by the age of 1 to 5. Proximal muscles are usually affected first, with the lower extremity muscles being affected before upper extremity. These children are often in a wheelchair by the age of 12 and die of cardiorespiratory issues in their early 20s. Overall, I just wanted you to have an understanding on the types of muscular dystrophies out there and that there's many different ones. A thinking point here would be, since you have some general information on muscular dystrophy, would be what type of activity and participation limitations do you think you may see in a child who has Duchenne's muscular dystrophy? This is important to keep in mind as each type of muscular dystrophy can affect children in different ways. I thought these charts were very beneficial in describing to you the different types of muscular dystrophies, even though for this project we're just focusing on Duchenne's muscular dystrophy, but it is important to know all the different types because you don't know what you'll experience in the clinic. So here on the left is a chart just listing them out with the different symptoms and age of onsets that you may see of each, and the right is a similar chart, however it's from the book. But again, for this PowerPoint, we'll mostly be focusing on the Duchenne's muscular dystrophy, as it's a very frequent diagnosis that you'll see in clinic working with pediatric patients. So now that you can compare all the different types of muscular dystrophies, it's important to know the difference in them, as they'll all have different outcomes and prognoses for the patients that we see in clinic. Typical impairments throughout the lifespan of a child with Duchenne's muscular dystrophy, we kind of sectioned off into 4 different stages of their life: infancy to preschool, early school age, adolescence, and then their transition into adulthood. For infancy to preschool, there's not really any significant disability concerns here. This is more of the stage where the family is finding out that their child has Duchenne's muscular dystrophy, usually the age of 1 to 5. Here, the physical therapist can be giving education on the progression of the diagnoses to the family and answering any questions that they have. During early school age, the gait can be altered in a child with Duchenne's muscular dystrophy, such as having toe walking due to tight heel cords, a lateral sway, high step patterns, waddling, or Gower sign, and it also is harder for them to start climbing stairs at the ages of 6 to 8. Physical therapy management begins here and focuses on education, baseline gaining of information, and creating plans to limit activity and participation limitations. Here you also want to avoid fatigue in patients that have Duchenne's muscular dystrophy, even though they're at that active age playing with friends at the school. We need to watch for contractures and slow their progression. Strengthening has had mixed reviews in this population. For example, eccentric exercises is detrimental to the patient as well as immobilization. So trying to find somewhere in the middle. There has been mixed reviews with resisted exercise training. However, there's been good results with submaximal exercise training in this population. Stretching is much more beneficial for these children than strengthening, however, as the muscles, specifically the heel cords that we mentioned before, are becoming very tight. So let's think of some gait deviations and what muscle imbalances could cause them at this age, because we need to focus on keeping these children functional throughout their early school age. In the adolescence period, these children are losing the ability to walk as it's diminished, and they're going to be using more motorized mobility. Functional mobility and respiratory functions need to be closely monitored as well during this age, as they will start to decline. The physical therapist's role during adolescence is to assist the child in completing their ADLs, providing adaptive equipment as needed, and giving the patient compensatory strategies. We need to focus on endurance training, specifically on the upper extremities due to the loss of ambulation, which is also very important. We need to be careful in watching for contractures at this age, especially due to the loss of ambulation, as they'll be sitting in their wheelchair or their motorized mobility device. Contractures can decrease this patient's ability to complete standing activities, which we want to work on. This age is also at an increased risk for spinal deformation, so we need to watch for postural adjustments, specifically when they're in their wheelchair. We can consider using orthoses for standing and walking abilities in these patients at this age. These should be given to the child when their 10-meter walk score is over 9 seconds, as a score over 9 seconds can predict loss of ambulation within 2 years in this population. We need to remember to always teach proper positioning to the child and family members in their wheelchair as well. So as the child makes their way into adulthood, many new pressures are at the child, such as societal issues with education and the consideration of assisted ventilation in those with Duchenne's muscular dystrophy as their respiratory system begins to decline. In this stage of life, the patient's respiratory system does become impaired with their functional mobility, which we need to keep track of. Things like a hydraulic lift may be needed for transfers of the patient. Overall, in this stage, having the physical therapist be there for the patient and family is very important as the child reaches the terminal stages of their lifespan. Overall, on this slide, we need to think about what we should be assessing during treatment of these patients during the different parts of their lifespan. At the beginning, maybe more education on what to expect with the diagnosis, and early on, we are working on stretching, ambulation, and working on function, as this can be done by taking range of motion measurements, manual muscle testing, and gait speed tests. As the child's diagnosis progresses more, they become unable to walk, and we will need to assist in things like wheelchair fitting and education on proper positioning, along with prevention of contractures with increased upper extremity endurance training. Lastly, as the diagnosis reaches their terminal stages, we need to focus on more compensatory strategies to help improve this patient's quality of life.
As part of the exam and eval for patients with DMD, here are some of the main points that should be addressed. You're going to take a detailed history that's typically oriented around the family's concerns with any functional limitations that are noticed in the patient that do impact their ability to complete ADLs or participate in school or play with friends. For this specific diagnosis, it's important to make family-centered goals and keep an ongoing dialogue with the family with the patient's functional status. DMD is going to affect multiple systems within the body for these patients, so a thorough exam of the whole body is necessary. And since this disease is progressive, you'll be constantly assessing and reassessing these areas. As for what common impairments you may be looking for during the exam, Maribeth basically went into great detail for you in the previous slide, but I just want to reiterate that some common gait deviations you may find are that waddling with toe walking, a lateral sway, and a high step pattern. I listed an example video if y'all want to check it out. It shows a patient with DMD that has that waddling gait, a positive Gower's sign, and pseudohypertrophy in bilateral calves. So along with common impairments, you may also find very tight plantar flexors, hamstrings, and a TFL. It's also common for this population to have pseudohypertrophy not only in the calves, but also the deltoids, quads, or the forearm extensors. As for their posture, you may notice a slight or significant lordosis with winging of their scapula. Scoliosis is also very common in this population, but only those who are non-ambulatory. You may also find what's called a Gower sign, where the patient has to walk their way up with their hands from a seated or lying down position to standing. So there are several findings that we'll have to incorporate in our plan of care and try our best to decelerate the progression of this disease. For this population, we would still use very common test measures that we use with every other population. We're still going to assess their body function and structures by measuring their range of motion and strength, but that's due to possible contractures and weakness. We are going to assess their pulmonary function, since one of the main reasons that lead to death of this population is respiratory complications. We also want to assess their activity level by having them perform a 6-minute walk test to assess their endurance, since with this population, this is most likely going to be severely impaired due to increased energy expenditure with their movements. We can also time them going up and down 4 steps or performing a 10-meter run or walk, and that's depending on their mobility. There is also something called a timed Gowers, which is timing how long it takes the patient to move from a prone position to standing. When doing this test, you're also assessing their movements throughout the transition from the different positions. Also, for assessing their activity level, there is the North Star Ambulatory Assessment, Performance Upper Limb Module for DMD, and Motor Function Test. To assess their participation level, there is the Pediatric Evaluation of Disability Index, the PEDS-QL, the Egan Classification Scale, and the Health Utilities Index Questionnaire. These are all fairly new outcome measures and tools that we've not really discussed yet. I would go ahead and explain each one, but since this is only a 15 and 20-minute presentation, I just set it up for you to click on each one, and that will take you to a link that will describe each tool. When treating a patient with muscular dystrophy, there can be a long list of team members that we have to constantly be communicating with. As PTs, we are most likely going to be the ones who are frequently in contact with the patient. Therefore, it's up to us to make sure everything is being communicated properly to all these team members to maintain continuity of care. We need to make sure that if there is a change in the patient's status, that we do reach out to the necessary professionals to provide the best care. We may need to reach out to the physician and/or the specialist for an update on the patient's status and clearance for PT. We may refer the patient out to a nutritionist to help with their dietary needs, since DMD does affect the GI system. We also may reach out to orthotists to help the patient be more independent with their functional mobility. And also, if we are in a school setting, it may be beneficial to reach out to the teacher to see how they are functioning in class. Here's a list of different possible interventions for this population. It's important to focus on stretching and possibly night splinting to prevent any contractures from developing. The main muscles to focus on for stretching are the plantar flexors, the hamstrings, hip flexors, and the IT bands. Although as the patient does progress through their condition, you become more focused on the upper extremities, since the patient typically will lose function with their lower extremities first. So you'll then want to focus on stretching the finger flexors, the shoulder, and the elbow. Also, along with stretching and night splinting, it's been shown by multiple sources that concentric endurance exercise has a positive impact on the patient's condition. Again, when the patient is younger, you may focus on strengthening the lower extremities to assist with ambulation, but as they do progress, you may focus on the upper extremities to assist in transfers and routine ADLs. Posture is also an area to focus on for interventions with this population. The best position to slow the formation of scoliosis is to have them in a neutral or slightly extended position. This decreases the ability for trunk rotation and lateral flexion, and also increases weight onto the facet joints. The lordotic posture is said to delay the development of spinal collapse also. Depending on the patient's respiratory function, it would be beneficial to incorporate some inspiratory muscle training and breathing exercises. Postural drainage, percussion, and cough assists also have been shown to assist with respiratory function in the later years of their life. The use of BiPAP during the day and/or the nighttime is also recommended for this population. To assist with their activity, a standing program before or at the time of loss of ambulation can be useful in slowing the progression of contractures, preventing fractures, and decreasing the progression of bone mineral density loss. There will also come a time when they need to transition into a wheelchair, so there will be necessary interventions for maintenance with wheelchair use. Besides working on their body structure and function, it's important to discuss any necessary environmental modifications. They may need to make bathroom adaptations, have a ramp built at the home's entrances. They may need to get a van with a lift for their wheelchair. They may also need assistive technology for computer access, and this is especially if they're still in school. There's also the option of them becoming involved in adapted sports.
Depending on the stage of life a patient with Duchenne's muscular dystrophy is in can vary in what type of wellness program they will need. For a child who is in their adolescence, as stated before, may start to be losing their ambulation independence. Stretching is going to be very important in this population to prevent contractures of the lower extremities, as well as opening up the chest wall to allow for increased ventilation. There was varied evidence on how long to perform this for, but the evidence showed that 2 times daily for 5 repetitions while holding the stretch for 30 to 60 seconds showed the best results in this population. In Duchenne's muscular dystrophy, the phrase "use it or lose it" is often used. This is evident in the patient's ability to ambulate. Ambulation is often lost at an early age in this population, but it's important to practice standing and ambulating as much as possible. It is recommended to ambulate a minimum of 2 to 3 hours per day in this population to increase lower extremity endurance. Upper extremity endurance and strength training is also imperative as the child loses more of their ambulation abilities. In a study by Alam-Darglu et al., it was discovered that working on upper extremity endurance will help increase respiratory function in children with Duchenne's muscular dystrophy, which is great because it's like 2 birds, 1 stone type of thing. They focused on increasing upper extremity endurance in a t-shirt wearing time to increase quality of life and respiratory performance. This was done for 3 times a week for 8 weeks. The lower extremity strengthening program in Duchenne's muscular dystrophy population, we know not to perform eccentrics and not to become immobile. However, the area in between is kind of gray. In an article by Law et al., it was found that moderate to mild leg strengthening program was performed for a group of Duchenne's muscular dystrophy children at home, and there were no signs of muscle damage, and they had increased improvements in strength and endurance. Breathing exercises are also very important in this population, as those with Duchenne's muscular dystrophy's respiratory function shows significant decline in the later stages. Lastly, patient education is important on proper positioning to prevent contractures and postural abnormalities that are often seen in this population, such as scoliosis and increased kyphotic posture. I found an interesting article by Pradnya et al., which compared conventional PT to conventional PT plus yoga to increase heart rate variability along with respiratory functions in those with Duchenne's muscular dystrophy. While there weren't many discrepancies between the groups, both groups were found to equally maintain heart rate variability in those with Duchenne's muscular dystrophy, which is very important in this population. I put an example from the article on the right-hand side here to show you the different types of PT treatments that were used for this study.